go ahead and get started. Dr. Shannon Wells is going to present today, and so every third year or fourth year MedPeds resident in the program, as part of their professionalism, scholarly activities, requirements, presents a grand rounds. So Shannon's actually, I think, our first one for this year. She wanted me to point out that there is candy. The coffee is from the previous lecture. So obviously anyway, Shannon is going to present designer drugs in teens, a very topic, and so what she has to say.
All right. Well, hey everybody, I'm Shannon. I'm doing designer drugs in teens. I actually did this topic when I was doing my adolescent month and found it to be really fascinating and decided I was just going to kind of expand on the topic, add in a couple of more designer drugs, and do this for my grand rounds. So my objective today is to assess the development of the adolescent brain and why teens use drugs, to identify some of the signs and symptoms of designer drugs and how to manage these patients, and to evaluate the newest technology used to try and detect designer drugs. I have no disclosures. I just find this topic really, really interesting. So why do teens do drugs? Well, there's a lot of things that make them want to do drugs. Their friends are doing drugs, their friends are pressuring them to try drugs with them or to do drugs with them. They just want to fit in. They like the risk-taking behavior. They want to escape from whatever their reality is. And drugs are glamorized by the media, and maybe they're bored. So what about the teenage brain? Well, teens actually have a higher risk of addiction because their brain is still developing. It's still relatively immature compared to a 24-year-old brain. And as you can see in this picture, the more red-yellow, the less mature, compared to the more blue-purple, the more mature. And there was actually a study done by Conrad et al. That looked at adolescent brain development. And what they saw was that there's this reorganization that's taking place in the adolescent brain, and that during this time period, the limbic reward system is actually maturing a lot quicker than the prefrontal cortex. And the prefrontal cortex is your, critical thinking area. It's the one that the area where you stop and you think before you do something, compared to your limbic reward system where you're doing what you got to do for the reward. So you've got this, you've got hormones that occur during this time that also can kind of help restructure the brain. And you've got this reorganization that makes teens susceptible to environmental influences, both the positive and the negative. And so this is kind of a picture showing what I just said, where you see the limbic system is maturing a lot quicker than the prefrontal cortex, and here's the adolescent period, and here's what they consider the riskier phase. And so they actually did a little experiment where they had about 50 patients, anywhere between 13 and 30, and they divided them into age groups. And what they did was they put them in a simulation car, and they put them alone and with 2 other people, so it's 3 people total. And what they found was that the 13 to 16-year-olds alone, when they were driving the car, they would stop at the stoplight. And if you didn't stop at the stoplight and you drove through it, you hit a brick wall, and that was considered risky behavior. And what they saw was that these 13 and 16-year-olds by themselves would stop. However, when they were with their peers, they would not stop and they would hit the wall. Compared with an 18 to 22-year-old who was more likely not to stop at the red light by themselves, but to stop at the red light when they have other people with them. So they saw that as these teens are maybe with their peers taking more risky behaviors in this study. And actually the NIH is doing the ABCD study, which stands for Adolescent Brain and Cognitive Development Study. And basically this whole study, the point of it is to really understand the teenage brain, understand teenage development mentally. And they want to understand the environmental, the social, the genetic, and these biological factors that affect the teenage brain and affect cognitive development. And they're still kind of collecting data right now, but hopefully within the next couple of years we'll have some good studies and some good papers that look at that. So why do we care? We're pediatricians. Why does this deal with us? Well, actually, it's in the media everywhere. We talk about bath salts. We talk about synthetic marijuana. We talk about ecstasy. We talk about methamphetamine, which are the 4 that I'm going to talk about today. It's everywhere. It's in Louisiana. It's in Texas. It's in Mississippi. It does affect us. Whether we're moonlighting in the ER or in our clinic and mom, her kid just took something, is acting funny, she doesn't want to go to the ER. She wants to go to her primary pediatrician. So you kind of need to understand a little bit about those and kind of know a little bit about what to do. So what is a designer drug? Well, basically a designer drug is a structural or functional analog of a parent drug that has been designed to mimic the parent drug, but to be basically classified as legal and or avoid detection by standard drug tests. So you want to get the high, if either the same high or a better high as the parent drug, be undetectable in a drug test, and quote unquote be legal. And that's what a designer drug is. So again, the 4 kind of main designer drugs we're going to talk about are MDMA or ecstasy, or as she likes to call it, Molly, cannabinoids, synthetic cathinones, and methamphetamine. There are 2 other designer drugs, GHB and PCP. However, I just didn't think I would have enough time to really talk about those the way that I wanted to. So we're going to stick to these 4. So why designer drugs? Well, the packaging is very colorful. It's very attractive. They're sold without an age limit, and I will show you how easily they are to get. They're available very, very easily, especially on the internet, and they're marketed as a legal high alternative. So kind of easy for them to get and quote unquote legal. And here, let me see if it'll actually pull up. Well, that did not work. Let's see. Just to show you how easy it is, I found this earlier this morning. So you can get synthetic marijuana for $22, 10 grams, right there. You can get ecstasy for $8. And just FYI, this is without a prescription. So. And it's categorized to help with ADHD. So, you know, if your kid's got ADHD, you don't want to go to the doctor, you can find this. So that's how easy it is to find this stuff online. And because it won't let me open the others. So we're going to talk first about ecstasy, and this is kind of the chemical structure of MDMA. What that stands for is 3,4-methylene-dioxymethamphetamine. So it's a methamphetamine. It's kind of in the amphetamine class. It's got stimulant and hallucinogenic effects. It was actually first made in 1912 and used up until the 1970s to aid in psychotherapy. However, after about that time, they started noticing it more in clubs and in raves. And by 1985, they started seeing a lot more overdoses with it in drug users compared to actually its medical effects in, as an aid in psychotherapy. So the DEA said, nope, it's got no medical use. We're labeling it as a class 1 drug, which means it's completely illegal. You can't have it on you, period, the end. Can't have it. However, there are actually researchers that are investigating it as a possible treatment aid for PTSD and anxiety in terminally ill patients and for social anxiety in autistic agents. And actually that resource I have down there is the paper that talks about wanting to start clinical trials with MDMA to look as a possible treatment aid for these. So what is it? Well, it's man-made, so we don't really know. But it can contain caffeine, it can contain cocaine, it can contain stimulants, it can contain amphetamines, it can contain bath salts. It's got a lot of names. It's, you know, also known as Molly, Ecstasy, E, X, Elephant, Hug Drug, Cadillac, Cowies, a lot of other names. Those were just kind of the ones I thought were the funniest. How do you use it? Well, it comes as a tablet, it comes as a capsule, it comes as a liquid, it comes as a powder. So you can snort it, you can swallow it, you can inject it, you can ingest it. There's all kinds of ways to get it in there. And I actually saw this and I thought it was kind of funny. It says, don't be daft, start with half. So, you know, if you're going to be smart about it. Just kidding, by the way. So what does it do? Well, it increases the release and slows the reuptake of three brain chemicals. Dopamine, which is going to increase your energy, norepinephrine, which is going to increase your heart rate and increase your blood pressure, and serotonin, which is going to affect your mood, sleep, and appetite. And actually, serotonin is also going to trigger hormones that are going to affect sexual arousal and trust. So basically, you've got a person with lots of energy, high blood pressure, high heart rate, happy mood, not wanting to sleep, not wanting to eat, who's sexually aroused, and very trustful. Kind of a scary combination right there. And what I want you guys to see, for those of you who picked up candy, look in your bag. Do you see something that looks very similar to this? To me, I would have thought that this was candy. And as a kid, I probably would have eaten it and probably would have been in a lot of trouble. So just, I want y'all to be aware that these look a lot like candy. All of these do. So you can have 2- and 3-year-olds who get a hold of this and think it's candy and eat it. So it can come into the ER or to your clinic that way, or if you do urgent care that way. So what are some effects? Well, actually, you start to feel some subjective effects within 30 to 60 minutes of consumption. It peaks about 75 to 120 minutes after consumption, and the effects are going to plateau about 3.5 hours later. It's going to alter your mood and it's going to alter your perception. What are some adverse effects? It makes you irritable. It makes you aggressive. It can give you depression. It can give you insomnia, anxiety, decreased appetite, and one of kind of the key hallmarks of the adverse effects is bruxism or teeth grinding. You also have an inability to regulate your temperature, so you can have high temperatures that result in a muscle breakdown, which can cause liver, kidney, and or heart failure, and there have been reports of deaths from this. It can also cause seizures, and it can cause an elevated heart rate. Let me see if it'll pull this up. And this just kind of shows you someone who's high on ecstasy.
No matter when your central
Not this part, though.
some of the air present. Our professional corps of certified technicians are there to meet the challenge.
To do it right, emergency repairs, precision tune-ups, quality installations. Since 1994, Southern Air has responded with guaranteed satisfaction and
So I want you to watch this almost dystonic type movements.
that can save you even more than bundled with solar panels. And remember,
It's actually a lot
Southern
louder
Air,
than I thought.
it's fixed right, it's free.
Doesn't make sense. Oh, I don't know why it's doing this still, but great, stop. Thank you. So, see how they just weren't really in their right minds, almost dystonic type movements, seemed very, very happy, no inhibitions whatsoever. That's kind of what someone on ecstasy looks like. So what about use? Well, in 2015, the Monitor the Future studies, and we'll talk a little bit more about what that is, but they saw that 3.6% of high school seniors reported using MDMA. So that's a decrease from 2014, which showed about 5% of high school seniors. And so what Monitor the Future is it's a study done by the NIH every year, and they send about 50,000 surveys to high schoolers, particularly 8th grade, 10th grade, and 12th grade, and they just pretty much ask them, have you used XYZ drug? What risk do you perceive? Do you perceive that there's a great risk in taking it? Do you disapprove of using it? And how available is it to you? So for ecstasy, what we've noticed is, and I wish you could see this a little bit better, this is roughly about 99, 2000, all the way to 2015. So you're seeing an increased ecstasy use right here, roughly about 2000, particularly in 12th grade. And we're starting to see a nice little decline right there with a couple of spikes here and there. But here in 2015, roughly 4.5% of 12th graders reported using it, 4% of 10th graders, and 1.75% of 8th graders reported using ecstasy in the last month. Now, what do they perceive? Do they perceive that taking ecstasy is a great risk? The 10th graders actually said, yeah, I think it's a great risk, more than the 12th graders and more than the 8th graders. But you're still above 40% who think that it is a great risk in taking it. How many disapprove of taking it? A good percentage of, particularly 12th graders, more than 80% of 12th graders disapprove of using ecstasy once or twice compared to 10th graders and then 8th graders. And then how available is it? About 40% of 12th graders think that it's very easy or fairly easy to get. So to me, this is very interesting data because first off, I don't know about y'all, but when I was in 8th grade, I was not thinking about any of this. I wasn't thinking, oh, where can I get ecstasy? How easy is it for me to use? So this kind of, especially for 8th graders, it kind of shocked me a little bit with the data. So treatment, how do we treat someone who is on ecstasy and possibly overdosed on ecstasy? Well, the key thing for them is they can't regulate their temperature. So they're going to be overheated. And likely they've been dancing, they haven't had anything to drink, or if they did, it was alcohol. So they're probably dehydrated. So they're at an increased risk for rhabdomyolysis, kidney failure, they have some hypertension, and they can have heart failure. So for the most part, for overtreating, most studies did show that you can just do evaporative cooling, you can cool blankets, things like that helped. However, there were a few cases where that didn't help enough, and they actually had to use dantrolene for malignant hyperthermia associated with ecstasy, and that did work. But basically, it's supportive care, your airway, breathing, circulation. If they have an acute toxicity caused by ingestion, you can do a GI decontamination with activated charcoal. However, it has to be done within about an hour after ingestion. And you can do whole bowel irrigation, but that's really only used for body packing of drugs. So are they addictive? Actually, science cannot prove that they're addictive, but it's more leaning toward yes, they are, because people do display some withdrawal symptoms like fatigue, depression, loss of appetite, trouble concentrating. And there are experiments that show that animals will self-administer ecstasy. And how do we treat this? We treat it with behavioral therapy. Problem with that is this is a long-term treatment. Medicaid and insurances really will only pay for about 2 weeks to 30 days. That's not nearly enough time to reduce recidivism and to kind of help them control their addiction. And then, you know, I found many a website like this, and it's basically, if you're going to roll, you need to roll safely. Again, I don't advocate this, though. Now we're going to move on to cannabinoids. Now this is the marijuana plant, and that's THC. Those are kind of the initial basis, but the synthetic molecules actually usually have nothing to do with this. It's just in name only. So what are the synthetic cannabinoids? Well, you've got 4 groups. You've got your THC analogs, your non-classic or cyclohexylphenyl analogs, your amino-alkyl indoles, which are your JWH compounds. Those are the most common compounds that we see. And then your fatty acid amides. And actually, these drugs were originally investigated for medicinal purposes. They wanted to look at them as analgesics to help with weight loss, to help with nausea, and to help with smoking cessation. Weight loss or weight gain, actually, for synthetic cannabinoids. And this is John W. Huffman. He's considered the quote-unquote founder of these molecules. He's an organic chemistry professor at Clemson, and he actually developed about 450 synthetic compounds to see if they can aid in multiple sclerosis, HIV/AIDS, and chemotherapy. However, the thought is that someone in Germany kind of read some of his papers, thought it would be cool to take this drug, kind of used his methods approach and created their own version of his drug and took it, and then got a good high off of it, didn't die, and started making it and selling it. And then he actually found out about it, and these are some of my absolute favorite quotes from him. He said, "I figured once it got started in Germany, it was going to spread. I'm concerned that it could hurt people. I think this was something that was more or less inevitable, but it bothers me that people are so stupid as to use this stuff. They're playing Russian roulette. I mean, it's just like taking a pistol with 1 bullet in it and spinning the chamber and holding it to your head and pulling the trigger." And it really is. So what are other names for it? There's K2, there's Spice, Potpourri, Black Mamba, Crazy Clown. These are, again, Class 1 DEA. Can't have them on you, period, the end, can't have them. And they're man-made chemicals that are applied to plant material and marketed as a legal high. Now, plant material can mean marijuana, but it can mean pretty much anything that's out in the backyard. So you don't know what it is. How do you use it? You can smoke it, you can mix it with marijuana, you can ingest it, you can spray it, you can vape it, and you can actually take this right here and almost create an herbal infusion like a tea and drink it that way. Now, what do these molecules do? Well, what they do is they bind to the CB1 and CB2 receptors in the brain, and they actually bind tighter and they bind longer than the THC molecules. So where are the CB1, CB2 areas in the brain? Well, you've got them in the cerebral cortex, the hypothalamus, the amygdala, the hippocampus, the basal ganglia, the cerebellum, the brainstem. So they're everywhere, and they affect all different regions of the brain. What are some adverse effects? Elevated blood pressure, elevated heart rate, bloodshot eyes, which is something you also see with marijuana. They can have swaying due to effects with the cerebellum. They can be vomiting. And there are studies that have shown that these have caused myocardial infarctions. Psychological effects, they can have anxiety, they can have paranoia, seizures, convulsions, and short-term memory loss. And then this is kind of a pictorial showing what I just talked about. But what I like about this is, you know, if you suspect someone's used synthetic marijuana, please call 911 because these symptoms can be life-threatening. And that is true. And it just gives you a good picture representation of what this drug does. So these kind of started coming to the U.S. around 2008, 2009, and that's when we really started collecting data. And again, it's the National Forensic Lab kind of started looking at Poison Control Center data and started creating this kind of pictorial representation. So in 2009, it's kind of sporadic. By 2010, it has spread like wildfire. And by 2011, 2012, it's just about everywhere. So what about teens? Well, there's actually been a significant decline in the past few years. And actually the prevalence in 2011 and 2012 of this use was about 11%. And in 2013, it dropped from 11% to 8%. But it's still one of the most prevalent illicit drugs used by teens. It's only number 2 to marijuana, which is basically that use has been unchanged. And then this is kind of a pictorial showing what I just said. So you've got the use right here, and it's just nicely declined down. We would like to see it kind of right there, though. What kind of bothered me was you see a nice steep decline here. For 8th graders, it's not much of it's almost, to me, more of a plateau. Not quite a plateau, but not enough of a steep decline down. So there's still a lot of work we can still do to help keep these kids from trying this stuff and taking this stuff. So what is the Poison Control Center saying? Well, basically they saw, as of 2012, about 600-700 cases every 5 months or so. Then they saw a nice drop decline. However, in April 2005, it's a very high spike upward. And this is Poison Control Centers all around the United States. So what about Poison Control Center data last month? Well, what they saw was 22 calls of synthetic cannabinoid use in Texas, 16 in Florida, and 2 in Louisiana. So it is actually still here. And they don't have the most recent data from October in graph form. And this kind of just shows the same thing. Sorry, I couldn't quite figure out how to get it, but it goes 11, 12, 13, 14, 15, 16. So we're seeing, starting in 2011, 400 spikes all the way up to about 700 cases, then goes down. And then, kind of, again, trending downward until you get to 2005, and then in April, you have this nice spike here. It starts to trend down again, and then goes to about 300, all the way to about 150 cases. And let's see if this will work.
The Walking Dead, a growing drug craze, is turning people like these into zombies. It's synthetic marijuana. On the street, it's called Spikes, or K2, and it's showing up in neighborhoods across the nation. The drug is so strong, people go into a zonked-out state. Sometimes it can even turn peaceful people into crazies. New York City Police Commissioner Bill Bratton.
And so that's just kind of him saying that New York is taking a stand and banning the drugs. But that's just a video that shows you what these people look like, and these kids can come in looking like that as well. So treatment. Again, you're worried more of like an overdose type picture. Did they take too much of it? And what they can have is they can have dysphoria, anxiety, they can have seizures, chest pain, they can be psychotic, they can have hyperthermia, which can result in a rhabdomyolysis, and they can have an AKI. Well, how do we treat that? For the most part, again, it's supportive. So if they're very agitated or psychotic, we give benzos. If they have seizures, we start off with benzos. If the benzos don't help control the seizures, then we go to phenobarb. If they're hyperthermic, evaporative cooling. And actually, no studies have shown the need for dantrolene because evaporative cooling has worked. If they have rhabdo, you want to do a fluid repletion with normal saline. And you pretty much want to keep them in a calm, quiet, dark environment until the effects wear off. What about withdrawal? There have been cases that show that there is withdrawal. And when these people are withdrawing, they have anxiety, they have myalgias, they have headaches, anorexia, tachycardia, they can be depressed. Treatment, again, really just behavioral therapy, which, again, has its limitations, that nobody really wants to pay for it, and it is a long-term process. All right, now we're going to go on to cathinones. So basically, these are derivatives and the primary active alkaloid in cat, or Catha edulis. It is a plant that is seen in the Horn of Africa and the Arabian Peninsula that has been chewed for hundreds of years for its stimulant properties. And the key cathinones that we're really seeing here are mephedrone, methylene dioxypyrovalerone, and methylone. And these are chemically similar to amphetamines and to ecstasy. And again, they're also a class 1, DEA class 1 drug. So here I want you to see, here's amphetamine. This is the difference with amphetamine. You've got that right there. And here they're also very similar to methamphetamine. And here's the methcathinone. You just put a methyl group right there. And then you get a little bit fancier right there. So what are some other names for them? Well, you've got flocka, bath salts, which is the most common one, gravel, and plant food. And the key thing to kind of let you know that these are bath salts, they're always going to say, not for human consumption. Not for human consumption, even though, as you can see, people do consume them. And what they do is they bomb, or they wrap the powder in cigarette paper and they swallow it, or they can key it, where they stick a key into the powder and then kind of snort it. And you do multiple keys per gram. You can also administer it rectally, you can administer it gingivally, you can inhale it, you can give it IM or IV. So all different ways to use it. What does it do? It stimulates the release of dopamine, and it inhibits the reuptake of epinephrine, norepinephrine, and serotonin. And it's a hydrophobic molecule, so it very easily crosses the blood-brain barrier. And then this is kind of a pictorial that shows what it does. It can cause jerky eye movements, blurred vision, hallucinations. It can cause sweating, severe temperature elevations up to 105, 106. You can have increased heart rate, kidney failure, tremors, shakiness, skeletal and muscle damage, severe psychological anxiety, rage, psychosis. They can have seizures, headaches, increased reflexes. So again, it's a systemic effect.
It's cheap, it's accessible, and in some parts of the country, including here in South Florida, it's becoming more popular than cocaine. We're talking about flocka, a synthetic drug similar to ecstasy but far more deadly. Here's Bobby Brooks with our NBC station here in South Florida, WTBJ, reporting from Fort Lauderdale.
Today, the Broward Sheriff's Office did their best to educate the public in North Lauderdale about the new designer drug, flocka. Well, I can tell you, deputies didn't hold back. They started by showing us this video of people high on it, and all the rumors we've heard now seem more like fact. The side effects of superhuman strength, your body temperature rising to 105, 108 degrees. That's why this person had his family dump water on him. And this man took his clothes off and ran around town right here in Fort Lauderdale. We see and hear paranoia.
Please, and I talk.
Relax.
Please, and last time I shook and I talked.
And just odd behavior.
So, again, kind of an overview of what these drugs can do. So, again, these drugs really started coming to the U.S. in 2008, 2009. We started collecting data. Again, this is mostly Poison Control Center data, and we see how it's Sporadic in 2009, 2010, it's grown even more. By 2011, it's basically everywhere. I don't know how Alabama got out of it, but who knows? Who knows? Yeah, that's what it is, just non-reported. So by 2012, it's, again, basically everywhere. And what's Poison Control Center seeing? Well, actually, we're starting to see a decline in it for the most part. So you get up to about 700 cases in 2011. By 2016, about 50 cases throughout the poison control centers in the United States. So we are seeing a decline in use. So what about these teenagers? What is the Monitor the Future study showing? Well, it's showing that actually 0.4% of 8th graders, 0.7% of 10th graders, and 1% of 12th graders report using bath salts in the last year. So we do still have kids using this stuff. So what are some side effects? Well, again, anxiety, paranoia, extreme aggression, mydriasis, hallucinations, tachycardia, dehydrations, hyperthermia up to 105, 106, seizures, and there have been deaths associated with it. Effects from this drug can last as few as 3 to 4 hours. However, it can linger for several days. And actually, studies have shown that there are worse outcomes when you snort it or you inject it. So what about treatment? Well, like everything else, it's supportive, really. You use benzodiazepines for agitation and for seizures. For hypothermia, all the studies have shown that aggressive cooling has worked. They haven't had to use dantrolene. And there's actually a hyponatremia associated, particularly with the mephedrone, but it's not really well described. And in the literature, it was treated like an ecstasy-induced hyponatremia, where you treat it with water restriction and hypertonic saline. So withdrawal. Actually, there was a survey that looked at 1,500 users of the drug, and they reported strong cravings and to repeat or increase doses of usage, particularly after taking mephedrone. And what about the withdrawal? What physical symptoms can you see? You can see anxiety. They're going to crave the drug. They'll have a decreased appetite, increased or decreased movement, lack of motivation, sleepiness or sleepiness, and they can have vivid or lucid dreams. Treatment, a little bit better with this because I think the media's really focused more on it. So there's more cognitive behavioral therapy. There's contingency management or motivational incentives. There's motivational enhancement therapy. And a lot of this, they do a lot of behavioral treatments that are geared to teens. It's one of my favorites. All right, and last is methamphetamine. So what is it? It is a powerful, very highly addictive stimulant that really just kind of affects the CNS. It was developed in the early 20th century from amphetamine and was originally used as a nasal decongestant and a bronchial inhaler. But when you compare it to amphetamine, more doses get into the brain and it tends to stay on the receptors longer, so it is considered a more potent stimulant. Unlike the others, though, it is actually a Class 2 drug, which means it is legally available, but only through a non-refillable prescription. So what are some names for it? Well, they can call it crank, chalk, crystal, fire, glass, go fast. You can snort it, you can smoke it, you can swallow it, you can inject it. And it comes as a white pill or powder, or it comes as pieces of glass or shiny blue-white rocks of different sizes. It can be yellow-colored as well, but the more yellow it is, the more impure it is. So what does it do? Well, it releases dopamine very, very quickly into the brain, which causes extreme pleasure. And it's called a rush or a flash. And once the effects have worn off, you've got, of course, less dopamine, and then you go into a depression because they want that rush or that flash again. It also damages serotonin neurons in the CNS, and studies have shown that it does reduce gray matter volume. And this is a lady who used it in kind of a 10-year progression with mugshots. So what are some adverse effects? You have increased wakefulness, increased physical activity, decreased appetite, increased breathing, increased heart rate, increased blood pressure, increased temperature, and possible irregular heartbeat. What are long-term effects? They can be anxious, they can have confusion, insomnia, mood problems, very violent behavior, very, very paranoid. They have hallucinations, delusions, weight loss, severe dental problems, and we'll show pictures of that later, and then intense itching that leads to skin sores from scratching, which is a common thing that we see with meth abusers. And again, this is kind of a pictorial that shows you how it's a systemic effect. with use. So what about age? Who all is using meth? Actually, 24% are under the age of 18. That's our patients right there. And then 35% are 18 to 23, so still a good chunk of our patients. So basically 59% is in an age range that we see. So this is something that we will be dealing with, whether it's in the ER or, again, a mom whose child got it and they don't know what to do, so they bring it to their pediatrician. So I had 2 videos. This one's actually my favorite one. This is a lady who is on meth. And again, just kind of watch and see how dysphoric.
They popular travel websites show you all hotels, right? Well, they don't. Actually, you're kind of hotel blind.
I wasn't expecting this part.
Different websites.
Hey, I need you, Daddy.
What I can tell.
Oh. What happened to her, Angela? Oh, nothing. Can I pick my bag up?
You want to sit down and see how she kind of looks out of it, not in her right mind? More balance. And kind of an almost dystonic movement. All right. So what about teen meth use? Well, according to the National Institute on Drug Abuse, over 12.3 million Americans 12 and older have tried meth at least once. And this was a little tidbit that I found really interesting. Methamphetamine's purity decreases the closer the production is to the Mexican border, most likely a result of drug trafficking from Mexican locations. And if you think about it, a lot of the methamphetamine we're getting here that's not made in bathtubs and backwoods is likely from Dallas, which is likely from Mexico. So we're probably not getting the purest of stuff here. So again, what does Monitor the Future show? Well, Monitor the Future looks at the trends in prevalence of methamphetamine for 8th, 10th, and 12th graders, and then it looks at it in age, at age ranges. So what it's showing is a lifetime, 0.8% of 8th graders have tried it. 0.3% have tried it in the past month. That's 8th graders. And then if you look at ages, for ages 12 to 17, 0.3% have used it in their lifetime, and 0.1% have used it in the past month. And 18 to 25-year-olds, 3.3% have used it in a lifetime, and 0.4% in the past month. These don't sound like big numbers, but when you look at it at a total population, there's actually a large amount of kids that are using this stuff. And so what are some faces of meth? They usually, what I've found is they like to start with the first mug shot and kind of the worst mug shot. So this was her, and this is after a meth lab explosion. These are the sores that we were talking about right here. And for her, she was actually a teen beauty queen who wanted to lose weight, so she tried methamphetamine, and this is kind of a progression, and now is a prostitute and addicted to methamphetamine. What do the teeth look like? Really bad. Really gross and really, really bad. So what about overdosing? What do we see? Well, we can see an abnormal heart rhythm. We can see elevated temperature, muscle aches, confusion, high or low blood pressure, overactive and over-responsive reflexes, muscle aches, severe agitation, hallucinations, paranoia, rapid breathing, and some urinary hesitancy or difficulty. How do we treat it? Depending upon the time of use, you can use activated charcoal, but that's usually within about an hour of use. It can damage the kidneys to the point where there is a need for hemodialysis or peritoneal dialysis. If they're, again, very agitated, benzodiazepines can help with sedation. If they're very psychotic, you can use antipsychotics, and you can use beta blockers for CNS or cardiovascular toxicity. Are they addictive? Yes. How do you treat it? You can use cognitive behavioral therapy, or you can use the matrix model, which is relatively new, and it's a model that kind of is a patchwork model. It takes a little bit of cognitive behavioral, a little bit of psychotherapy, a little bit of this, a little bit of that, and it really tailors it towards the specific patient. Problem with that, it's very expensive. It's about 15 to 18 weeks total in rehab. Nobody's going to pay for it unless you've got a lot of money, so not a lot of people get this, but it actually has shown rates of reduced recidivism. What are signs and symptoms of addiction? Again, they're anxious, they crave the drug, they're fatigued, they have a decreased appetite, increased movement or decreased movement, lack of motivation, they are either really sleepy or can be sleepless, and they have vivid or lucid dreams. All right, what about testing? What can we do to test? Well, first we need to know kind of how long do these drugs stay in the system. Well, for ecstasy, it can stay in the urine 3 to 4 days. It can stay in the hair up to 90 days, but usually about 30 to 60 days. And it can stay in the bodily or oral fluids, so blood or saliva, 3 to 4 days. Synthetic cannabinoids in the urine, about 3 days. Body fluids, 1 to 2 days. Hair, there was no good source that I could use, but from what I read, about 30 days, 30 to 60 days. For bath salts, stays in the urine 2 to 3 days. There was no real good data about how long it stayed in the hair or the body fluids. Hair, probably 30 to 60 days, and they just didn't know for body fluids. And then methamphetamine can stay in the urine 3 to 5 days. Hair, up to 90 days, but about 30 to 60 days usually. And body or oral fluids, 1 to 3 days. So how do we test them? Well, we do urine drug screens. So what that is for the initial screen, it's an immunoassay, and it looks for antibodies to detect the presence of the drug. But it doesn't measure the specific amount of the drug in the urine samples. So what you can do is you can confirm it with a gas chromatography or mass spectrometry, and that IDs the molecule based on characteristic fragmentation patterns at specific retention times. And it's the most accurate, sensitive, and reliable method of testing. However, it takes a long time, and it's very expensive. And so what it is you, for the gas chromatography, you inject a small amount of sample, and it kind of goes through the column, and different densities kind of dictate the travel time. So the heavier the molecule, the slower the travel time, and then it can detect it right here. And you can also do a mass spectrometer where, again, you put the source right here, it shoots an ion beam at it, it breaks it apart. Heavier molecules go slower than lighter molecules. And how the substance breaks apart kind of tells the technician what the substance is. The other thing you can do, and we really don't do this, it's more for court purposes and legal purposes, but you can test the hair. So what they do is they collect the hair, they ground it into a powder, and they run it through a high-performance liquid chromatography or the gas chromatography mass spec for analysis. Some pros of this is the drug of abuse can be detected, and it can detect cannabinoids, cocaine, amphetamines, and mephedrone. It is less invasive. It shows a relatively good history of drug use because it can detect it up to a month from previous use. Cons, it's very difficult to prepare reference hair standards where you can concentrate the drug. It's hard to standardize the decontamination and extraction procedure, and it's hard to really do minimum standard performances in the different labs. So every different lab has their own way of kind of breaking it up and putting it through the mass spec. There's no standardized way. Again, it's expensive, it's time consuming, so we don't usually do that here. If it's going to be done, it's usually for legal or court purposes. But what about bath salts? Well, actually, there's a lot of research and testing labs that have used liquid chromatography, tandem mass spec, or gas chromatography mass spec to kind of develop qualitative and quantitative testing procedures for assaying bath salts in blood, urine, serum, and plasma. Problem is, there's a bunch of them coming out, and they keep changing the composition of them. So by the time a lab creates something new, there's a new drug, new composition, what they just created is not going to work. And I added this website in because it kind of shows you where you can go, like if you're in a private clinic, and you can buy these these drug tests. Other issue is I never found anything that talked about the sensitivity or specificity. So I don't know how sensitive, I don't know how specific these are. But you can buy them. There are multiple websites just like this one. So basically, in conclusion, reorganization in the brain takes place during the adolescent years. The limbic and reward system is going to mature a lot faster than the prefrontal cortex. So that, along with the social factors, peer pressure, whatever's going on at home, are they bored, that can increase risk-taking behaviors. However, teenage usage of these drugs does appear to be decreasing based upon Monitor the Future, the NIDA, and the Poison Control Center data. But usage of these drugs does appear to come in waves. So it'll decrease, and then it'll increase, and then it'll decrease, and then it'll increase. The signs of overdose for designer drugs, for the most part, include hyperthermia, rhabdomyolysis, seizures, and psychosis, but it can include a whole array of things. Treatment is supportive, and it's very system specific. There is no magic pill to reverse the symptoms of overdose, unfortunately. And there are ways to detect these drugs, particularly in the urine and the hair. However, these are time-consuming and very costly, and for the most part, we usually don't do them. And I just really like raccoons.
The longer the teachers, is it controlled for the ages of the kids in each grade? So let's say you put somebody like that, is it controlled for a 16-year-old in 8th grade?
As far as I know, it does not. From what I read, it just sends out 50,000 surveys.